All right, so the SIRS and MODS, there isn't a whole lot in your book, so we're going to kind of go over it PowerPoint-wise. What's SIRS?
It's the System Information Response Syndrome.
It's the Systematic Inflammatory Response Syndrome. It's right here, guys. I know this rainy weather has us all half asleep. Good, and then MODS is multi-organ dysfunction.
Syndrome.
All right. So when we talk about SIRS, it's very non-specific. It can be caused by all sorts of different things. There's a little diagram there for you. When we have SIRS and infection, that's when we call it sepsis. But you do not have to have an infection to have SIRS. So other things that can cause it, burns, tissue trauma. So say your patient got into a car accident or got crushed between two cars or got crushed under a piece of heavy equipment. The crush syndrome, the crush injury can actually cause SIRS. Because remember, it's just an inflammatory response syndrome. So it doesn't have to have an infection to go along with it. I know in the hospital we hear it a lot with the sepsis, so kind of link them together in your mind, but they do not have to be. Abdominal infections can cause it, abscesses, pancreatitis, any sort of, obviously, bacteria, fungus, yeah.
What about snake bites?
Snake bites could cause it, right? That's a poison or a venom. Any of our shock states can cause a SIRS reaction. Surgical procedures, going in and having any sort of surgical procedure done can cause it. So what's the criteria? Do you guys know? So we have a temperature. What's the temperature?
It can be either elevated or...
It can be elevated or low. So what are the criteria, the break-offs? It has to be below?
It has to be below 96.8.
96.8 or above?
100.4.
100.4. So you might see it in Celsius because, you know, they like to throw the Celsius numbers at us out there. So remember, normal is what? Celsius.
96.8.
Celsius.
36.
37. 37 is normal. And for SIRS, it can go from below 36 or above 38, which is that 96.8 or 100.4, right? So normal is 37. SIRS criteria says below 36 or above 38. What about the heart rate?
Above 90.
Above 90, good. So heart rate greater than 90.
And then blood pressure has to be low.
What about respiratory rate?
Greater than 20.
Greater than 20. So I think that the book, the 10th edition, actually raised it up to 22.
Oh, okay.
So yeah, if you look on page 1592, there's a little chart, and it says diagnostic criteria for sepsis. So basically, remember what I said, sepsis is SIRS plus an infection. So at the top of that chart, it says infection documented or suspected, and some of the following. So that some of the following basically is our SIRS criteria. It goes a little bit deeper than the normal SIRS criteria that you would normally see. But now it does have the fever in there still. The fever, actually, they raised that up to 38.3. We're still going to tell you the 100.4. Heart rate greater than 90. So the respiratory rate now is greater than 22.
Okay.
The altered mental status is something that now has gone into that QSOFA. When they start talking about the QSOFA for SIRS, they start talking about the altered mental status. Before, we didn't really look at it. What about our white blood cells?
Low.
Or
high.
high, right. So they have to be lower than what?
Lower than 1,200.
Lower than 4,000. Or higher than 12,000. Or you can have a white blood cell count with greater than 10% bands, right? So what does that mean?
Immature white blood.
Yeah, they're just immature, so they're just producing.
Greater than how many?
10%. So what's MODS? We said it's what?
Multiple
organ dysfunction. So the key word obviously is multiple. So when you have a patient and they are having trouble breathing and they have some crackles and their O2 rate's low, would they be in MODS?
Yes.
No,
Or is
because
it
it's
lungs
still
and
one.
heart?
It's still one
Lungs and heart.
one organ, right?
You get the backup of the lungs with the crackling, and then you already have issues with the heart. Is that like two?
It could be. So if you see a question on a test, NCLEX, ATI, our test, and we start giving you, here's 6 patients, which one of them is in MODS, right? You're going to make sure that anyone that you answer is going to have 2 different organ system failures, right? So there has to be 2 because it's multiple or more. What does it result from?
Shock.
SIRS, right? So it basically your patient goes into SIRS and they very quickly can go to the MODS side of the criteria there. So our goal, obviously, for SIRS, see down at the bottom, SIRS nursing priority, is to keep our patient from going into MODS. So basically, SIRS is just some sort of like inflammatory response that your body does not have any control over. So it can't say, whoa, 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 calm down there, Haas. Like, you're going too fast. We don't need to throw out all these cytokines and everything else. So the primary goal
And to keep them stable.
is what?
Keep them stable and alive.
Keep them stable and alive. So what's causing the organ breakdown, though? You have SIRS, so you have all this inflammatory stuff going on, right? So do you remember in the blockage, whatever's causing it? So usually it's going to be organ perfusion, right? So you have all this inflammation. So what happens when your body starts throwing out like your inflammatory mediators? So let's say like there's your cytokines and your histamine and everything else, right? It's going through those veins and capillaries. Goes out there, and basically the inflammatory response inside the capillaries and veins is that the walls start breaking down. So then you start having that same response that we had yesterday with the DIC, right? So now walls are breaking down, they're getting a little leaky. Your body says, oh crap, that shouldn't happen. So let me throw some coagulants up in there because we want to patch. We'll just throw in our white blood cells and everything else because we want to patch these leaky areas that are happening now. And then your body says, oh, whoa, whoa, now we're throwing this stuff in. So you can see how we very quickly would go from like SIRS, and then if they had sepsis, we could quickly get to DIC just from the inflammatory response inside the body, starting that cascade that we talked about yesterday. So our primary goal with SIRS and MODS, obviously, is tissue perfusion. Because if we can keep the organs perfused and working, then we're not going to have the breakdown of the organs. So the primary goal is going to be organ perfusion, tissue perfusion. So the inflammatory response is causing that damage to the endothelium that I just talked about, the increase in vascular permeability, and the activation of that coagulation cascade. When we talk about the organ and metabolic dysfunction, we start talking about all the different systems and things that can happen. So let's talk about the respiratory system first. So our respiratory system is often the very first one that you're going to see some sort of sign of dysfunction. Sorry, I've drank too much coffee with cream today, I think. I know.
Cut back on coffee.
I know. I haven't cut back on coffee. So remember I was talking about that leaky vascular system, right? The permeability that happens. So that's just not happening in just, your arms and your legs and the veins that we think about. It's also happening in places like our lungs. So that's what oftentimes is happening is you start having the alveolar edema. No, that starts getting clogged up. You get that same thing. The mediators are everywhere, so you're getting that leaky permeability. So you got stuff kind of going where it doesn't belong in there. And then what happens is you get a decrease in the surfactant. And then next week, Ms. Hofrichter is going to talk about ARDS, and she's going to talk about the VQ mismatch. But basically what that's saying is you get fluid in places it doesn't belong. So picture your alveoli as like a cluster of water balloons, right? So say we have this water balloons hanging. There's not usually supposed to be water inside there, right? But now we have these leaky capillaries that are leaking everywhere. So now we have this water in there, and the oxygen that normally can get through the bottom of those balloons into the sacs that are going to go out and oxygenate your body, it has to make its way through all that water now, right? You think that it's getting through just as well as it was before all that water was there? No. So you're having poor oxygen exchange. So that's your VQ mismatches. It's just not oxygenating the way it should. So basically, if that's not taken care of pretty quickly, it's going to turn into ARDS, which we'll talk about next week. What about the cardiovascular system? What do you think's going on there? Ischemia. So the same thing's kind of happening, right? What's that? What's that?
Inflammation too.
Right. So you same thing. You have the inflammation. So your body is going to responds to the inflammation. It's going to try and pump out more cardiac output.
Then once it can't compensate, it's going to decompensate.
It's right. So your body can only do that for so long before it has to stop, kind of like a rubber band, right? I can pull that rubber band and it'll bounce back, it'll bounce back, it'll bounce back, and then eventually it gets a little doesn't bounce back as quickly, and then kind of like your favorite pair of pants, elastic waisted pants. Eventually, after you wash them enough, they don't stretch anymore. Same thing with our, the heart's kind of like the same thing. You can only do so much. So it's clamping down, it's trying to compensate, and then it can't. So what do you think our patient's going to look like if we have leaky vascular system?
Blue.
Yeah, they're going to have some modeling. What do you think their cap refill will be like?
Slow.
Decreased, right? Yeah, more than 3 seconds. What do you think the heart's going to do to try and increase that cardiac output?
It's not pumping hard, so it can't pump anymore.
Yeah, you're going to be tachycardic. Good. What about the neurologic system? What's always the very first thing that you notice in the neuro system that causes LOC? Oh, there it is. So changes in LOC, right, is always going to be your first thing. So you have the same thing going on there. You have the inflammatory mediators, impaired perfusion, hypoxemia. It's often an early sign of MODS if your patient suddenly, obviously they're your patient, they have something else going on, right? So that respiratory system maybe has started, so we're treating the respiratory system, they're in ARDS. And then suddenly now they have a decreased LOC. So at that point we're going to say your patient is in MODS because they have two systems that have started breaking down. So your patient might become agitated, confused, lethargic, even comatose. Talk to me about decreased perfusion and breakdown in the renal system.
Decreased urine output.
Decreased urine output. So are these patients that come in with chronic kidney injury? Chronic kidney disease, rather? No. So you guys see patients all the time where they have acute kidney injury, right? So something else was going on with your patient, and basically like a secondary acute kidney injury happens. So that's these patients because of the hypoperfusion and that release of the mediators. You're going to have the decreased perfusion to the kidneys. So the big sign that you're going to look for is that decreased urine output. What about the GI system?
Distended abdomen.
Mobilization. Decrease like it stops, so you get.
Yeah, so decreased mobility.
So if you got decreased, then your stomach gonna distend.
Right, so you could end up with a paralytic ileus, and you'll have the distension or is that the word that you used, distension?
Distended.
Yeah. So what about the decreased perfusion in the area, though? Or even with the decreased mobility, what's going to happen? What lines our GI system? Mucus, and lots of it, right? So what does that mucus do?
The bacteria.
It's a protective barrier from bacteria leaking out. We don't want the bacteria that's in our intestines out in our peritoneum, right? What happens then? You get septic. So that mucus is keeping that from happening. So if the gut isn't being perfused and we're not keeping it moving by feeding it, we can end up with breakdown of that mucus, and then we get what's called GI translocation, where the bacteria basically starts leaking into the gut. That's never good. Yeah, translocation. You also get ulcers, GI bleeding. So what are some things that we would do for this patient? Yeah, PPIs or H2 receptor blockers. Who said feed them? Did someone say feed them?
Yeah, nutrition.
Who said that? I hear it. I don't see a voice moving. Is that you, Jay? Did you say that? I saw Chris go like this. Yeah, you would feed them. You want to make sure that when you have a patient that's sick, and we'll talk about it more when we get into the shocks, we want to make sure that we're feeding these guys pretty early, because by keeping the gut moving and working, we're keeping blood flow there. So let's say your patient comes in, they're super sick, they don't start them on anything, they're not eating, gut's not moving. What's your body going to say? It's going to say, oh, we don't need the gut anymore, we're not using it, so we must not need it, so we don't need to send blood there, right? Use it or lose it. So we want to make sure that we're feeding our patients early, preferably by mouth. And if we can't feed them by mouth, then we'll do the enteral nutrition. Sometimes we'll do both if they can't compensate for the number of calories that are needed, because these are usually pretty sick patients. So their bodies are going to require 1.5 to 2 times the calories that they normally need. So if they can't get that calorie in, because do you feel like eating when you're sick? No. So if they can't keep up the caloric intake that the body's going to need to heal, sometimes we'll have to, even if they can do a little PO food, we'll also be giving them like TPN or PPN. Ooh. Hypermetabolic states. So it all has to do with the insulin resistance and the liver dysfunction. When we talk about sepsis and shock, we talk about wanting to keep these guys in a fasting blood sugars under 180. But we don't want to keep them too low, because that was actually shown to not be good either. So usually we try and keep them between like 110 and 180. And we kind of started with this, right? So you have those mediators that are in your veins and capillaries everywhere. And then the whole cascade starts and it leads to DIC. So the whole hematologic system. again, the mediators get in there, they start causing the leaky capillaries, right, in the veins, and then the white blood cells and platelets come and say, oh, no, gotta cover up those holes, and and then that whole cascade that we talked about yesterday happens. So what about collaborative care? The prognosis is poor. The mortality rate is 70 to 80% once you have a patient that's in MODS, if it's not taken care of pretty quickly. We want to prevent the progression of SIRS to MODS. So your way that you're going to do that, if you have a patient, even if your patient's there and they're not looking so bad, so I'm going to take care of these other guys because they're way worse off, right? This happens all the time. These guys over here look way sicker, so I'm going to take care of them, and maybe I don't check on my patient in 269 that I should be checking on every couple hours. Instead, it might have been like 4 hours since I've been in there, and they haven't really rang the bell, so the techs haven't gone in there. And next thing you know, you go in there, and they're not looking good at all. And the first time you see a patient like super sick with sepsis, you will be able to say, yep, that's what sepsis looks like. So you guys as nurses, especially new nurses, want to make sure that you're doing your monitoring on your patients the way you're supposed to be doing it, or at least every hour or so, even if it's just popping your head in every 30 minutes just to look at them. Oh, they don't look so horrible, right? Yeah.
So these are ICU. We only have one or two of these patients, and that's it, kind of a thing.
Not necessarily. I mean, it can happen quick on the floor, and you might be stuck with this patient until you can get them off to someplace or a bed opens someplace, right? I've seen pretty sick septic patients on the floor. Usually once they have some sort of sepsis going on, the MODS is started pretty quickly right behind it. So we want to make sure that we are taking care of their tissue oxygenation needs. We want to make sure that if we have lots of stuff to do with these patients, that we're spacing care out. If they're anxious, we're giving them something for their anxiety. We're providing a quiet environment. We want to make sure that we're preventing infections, especially if they don't already have one, right? So we're using our aseptic techniques. Making sure that if they don't need those invasive lines or catheters, that we get orders and get those out. Once we do suspect any sort of infection, that we act on it quickly. Again, we want to make sure that we're feeding them early. That we are treating anything that does happen with different organs, different systems, right? So if your patient does go into ARDS, and again, we'll talk about it next week, but we're doing aggressive oxygen therapy and probably mechanically ventilating them. If they are in DIC, we're doing all the things we talked about yesterday, giving appropriate fluid replacements and possibly heparin, depending on what's going on. If they're in renal failure, that they start them on dialysis or CRRT pretty quickly.